Hello, I'm going to be presenting coagulation disorders in pregnancy, and I have no disclosures. We will be discussing the mechanisms of coagulation, identify several changes in pregnancy, and present examples of coagulopathy in pregnancy as the bulk of our presentation. When we talk about mechanisms of coagulation, of course, normal clot formation is a very complex process. What we learned in school doesn't really fully explain how clots form, and therefore abnormal coagulation is very common. Because we have to take into account both pre-existing and acquired coagulation disorders in the pregnant woman, we have to understand how clot formation actually works. And we're going to start to illustrate that by cases. And case number one is a 32-year-old nulliparous woman with twins who was otherwise healthy. She was complaining of fatigue and new onset of edema, and was admitted with a ominous fetal heart rate pattern. The obstetrician said we had to go to urgent cesarean delivery, and when we entered the operating room, we noted that she had bright yellow discoloration of her skin and eyes and fluorescent orange urine when the Foley catheter was placed. After delivery, she had diffuse bleeding, which was very difficult to stop. Because of her coloration, we sent off labs and found that her bilirubin was dramatically elevated, but her transaminases were only slightly elevated. However, with an INR of 3.0 and a fibrinogen of 0.48, what we had diagnosed was complete liver production failure. Her liver had failed, and she had a condition called acute fatty liver of pregnancy. Over the next 24 hours, to fix her disorder, she received over 100 units of transfusions. What did she have? Well, when we learned, all of us learned in school about the coagulation cascade, we learned it as though it were an equation running from this factor to that factor. And the problem here was that this was produced by chemists who were looking for a cascade of clot formation, and therefore that's what they found. But what we now know is that this is actually not a true representation of how clots form. There is in the body no intrinsic or extrinsic pathway. Those are laboratory test tube comments of how it's measured. What we actually have in the body is something that is a lot more represented by this type of three-phase clot formation, where we start out with tissue factor binding activated factor 7A. And tissue factor, of course, is most often in normal clot formation released by damaged endothelial cells, but can, as we'll see later, be released by other cells. The factor 7A and tissue factor activate factor 10, which creates a little bit of thrombin flowing throughout your bloodstream around where that tissue damage was. And that thrombin acts as a signal, an alarm signal that binds with calcium and phospholipids to activate the platelet. And from here on out, the activated platelet is really the epicenter of clot formation, and it's on and around the surface of the platelet that the entire process works. We know that, for example, factor 11 binds the platelet as it holds on to both factor 9 and 8 and von Willebrand's factor, and in order to activate the 10A complex. The 10A complex binds with 5 as a prothrombinase complex on the surface of the platelet in a very specific binding receptor to activate prothrombin to thrombin, and that thrombin gets bound to the surface of the platelet. And if you have a microscope of the platelet surface, you see giant thrombin towers, and those thrombin towers then cause the fibrinogen to be cleaved to fibrin and to link a clot together. And it's this process on the surface of the platelet and around the proteins around the platelet that really activates normal clot formation. And this is why platelet determination is so important in not only regional anesthesia and obstetrics, but for all types of clot formation. I guess in summary, the coagulation system is a very complex network, And it's really part of the immune system. If you look at the components of the coagulation system and components of the immune system, you see that there's 100% overlap. Every single part of the immune system activates some component of coagulation, and back and forth and vice versa. And that plays a part in activation of consumptive coagulopathies. Now, I wanted to look at the electron microscopy of an activated platelet. Well, actually, this is chewing gum. But what we know about chewing gum is very sticky. And if you have a lot of chewing gum, it will cover up a hole. And that's what nature did in order to produce a platelet clot that covers up holes of damaged endothelial cells. And so it's a very specific process initiated by, around, and through the platelet function. During pregnancy, we have an increase in a lot of factors. In fact, most of the factors that are important for clot production and propagation are increased, and that produces a hypercoagulable state. In pregnancy, we can actually see that by measures, traditional measures of coagulation. Here you can see that prothrombin time, partial thromboplastin time are both shortened compared to control non-pregnant, the same subject. What we also see is that fibrinogen is dramatically elevated, sometimes twice elevated over non-pregnant controls, and that is an important marker we'll be talking about shortly. We know there is abnormal coagulation, and that can either be pre-existing or acquired. Pre-existing can be congenital. Acquired can either be from a disease process or because we doctors have given medications. When we talk about congenital abnormalities, it can actually be both sides of the equation. We can have people who have factor deficiencies and are hypocoagulant, or we can have hypercoagulant people. And when they become pregnant, the chance of having major thrombosis, either arterial or venous, is dramatically increased. For example, people with antithrombin 3 deficiency have a 1 in 3 chance of having a major thrombosis in pregnancy, which means that we have to provide them with antithrombotic treatment. And unfortunately, we do not have great data on this subject right now. We don't have large series, we don't have extensive laboratory data describing how pregnant women are different. We know that an 80-year-old, 50-kilo woman having a hip replacement is different than a 36-year-old woman who weighs 80 kilos and is hypercoagulable to start with, and then hypercoagulable from pregnancy. However, the American Society of Regional Anesthesia, when they put their consensus 4th edition statement together here, said, of course, since we don't know, we have to default to a more conservative stance. So we suggest the ASRA guidelines be applied to parturient, even though we know that that doesn't make complete sense. So they put this caveat in which says the risk of general anesthesia may be greater than that of neuraxial anesthesia, and exceptions or modifications of the guidelines may be appropriate. And that is the statement which allows us to alter our own local guidelines and local practices for these types of patients. I do want to give a shout out to the Society of Obstetric Anesthesia and Perinatology, which is starting to put their own consensus statements together. And this one on platelet and thrombocytopenia is an excellent review of the literature and practice recommendations. And I hope that this prevents the question, what platelet count will you place an epidural in, at the end of this presentation. But it does bring up patient number 2, who is a 36-year-old woman at 37 weeks in early labor, who has a medical history of antiphospholipid syndrome and lupus. And she did develop early in labor a deep vein thrombosis and had a bilateral pulmonary embolus. She was on 75 units subcutaneous heparin, and last dose when the induction was started was 6 hours ago. I met her 4 hours after her induction had started when she wanted to have an epidural. And the concern with antiphospholipid syndrome is there is no test to assess whether heparin has stopped functioning or are still actively anticoagulating this patient. So I chose to do a thromboelastogram. And what we see here is a 4-chamber thromboelastogram, TEG for short. And on the red, we see the patient's curve, and you can see that it is significantly prolonged. And in the green to the left there, you can see a chamber that has heparinase in it. What does this mean? If I run this test with heparinase, which eliminates the effect of heparin, you can see that there's a dramatic prolongation of the patient's native TEG, meaning she is still quite anticoagulated. After 8 hours, it started to resolve, and it took a total 27 hours before she had normal function. So she had to be off heparin, even 7,500 units of heparin for over 24 hours in order to return to baseline. We need to have more data. We need to have better understanding of how to care for these patients. And I think the future of research in obstetric anesthesia is going to include these types of things. So how does pregnancy impact coagulation? Well, as I pointed out earlier, we have a hypercoagulable state. We also have many pregnancy-related disorders, such as the first lady with acute fatty liver, which impact how the patient may form clot. But I think it's valuable in most of these to assess whether it is a consumptive coagulopathy or a dilutional coagulopathy, because the treatment and the goal for treatment should be slightly different for those two. Let me explain. Through case number 3. And this is a 37-year-old, 36-week chronic abruption. She had been stable for over a month, no medical history or surgical history. And you can see here her labs are pristine, her fibrinogen was elevated, consistent with pregnancy, and she was otherwise normal. She had a labor induction, and the obstetrician went in to rupture membranes, which he did successfully, and amniotic fluid came out, followed by profuse vaginal bleeding. The patient immediately became unconscious and started convulsing. Intraoperatively, a stat C-section was called. We immediately transferred the patient to the operating room shortly, just down the hall. 2 minutes later, there was an uneventful intubation, and 2 minutes after that, the baby was delivered and was crying shortly after delivery. So we saved that baby's life. How did mom do? Well, she appeared mottled and cyanotic. At intubation, the end-tidal carbon dioxide tension was only 5 to 10 millimeters of mercury. There was a profound bradycardia and hypotension, and there were 2 millimeter ST elevations in lead 2, AVF, and 5, the only 3 leads we were monitoring. Transesophageal echocardiography demonstrated a markedly dilated pulmonary artery, which is the Y-shaped structure in the center, which should be about 2/3 the diameter of the aorta, which is the circle on the left. We also could see streaming into the right ventricle, a sticky substance from the left ventricle, which is here, and was streaming almost like molasses into the right ventricle. We could see that this was only present on the right side of the heart. And finally, when there was a contraction, what we saw was that the interventricular septum bowed all the way into the left ventricle, meaning the right side of pressures were higher than the left. What exactly were we looking at this point? Well, it was quite concerning. And the value of the TEE was that we saw the exact moment that the heart stopped conducting, and yet there was still electrical activity. And so we diagnosed PEA arrest and started chest compressions within 2 or 3 seconds of that diagnosis. 1 milligram of epinephrine was given twice, and we did achieve ROSC after only a few minutes. The massive transfusion protocol was activated shortly after achieving ROSC. This is, of course, an amniotic fluid embolism, which we caught happening as we were watching, and that is diagnosed most commonly by pulmonary hypertension with cardiac rhythm abnormalities or cardiac arrest, and is not invariably, but often followed by massive and uncontrollable maternal hemorrhage. And this is a coagulopathy, which we use the term DIC, or disseminated intravascular coagulopathy. What is DIC? Well, DIC is a form of consumptive coagulopathy. And the important part about DIC is that it's really an overstimulation of the coagulation system, and specifically the immune response. DIC requires, true DIC, as opposed to generic coagulation, consumptive coagulopathy, requires an immune response where it's really the white cells that are releasing tissue factor in response to some kind of activation. And when the white cells are releasing tissue factor, there's an indiscriminate binding of factor 7A with that tissue factor. And so you get intravascular fibrin creation and deposition, microvascular thrombosis. And so throughout your entire body, there's consumptive of both the platelets and the protein. DIC can occur in a lot of pregnant states and is probably associated with most causes of maternal mortality. And that includes amniotic fluid embolism, as in this patient, the placental abruption. So the larger the surface there, the more activation and potential for immunogenic response to the placenta. There's preeclampsia and HELP syndrome, intrauterine fetal demise. As the longer that goes on, the more you see a breakdown of the placental barrier and activation of the maternal immune response. And finally, sepsis. On the other hand, we have case number 4. Case number 4 is a 31-year-old female, 36 weeks with a singleton pregnancy. This is her, she had a transvaginal ultrasound because her previous delivery was by cesarean delivery, and that ultrasound demonstrated a possible accreta. We scheduled an elective cesarean delivery for her. Intraoperative course was uneventful up until delivery of the neonate. Baby did well. Mother did wish to have additional children, and so the obstetrician looked carefully at the placenta and discovered that it was not a possible accreta, but a full thickness increta, meaning the placenta had invaded and grown deep into the muscle of the wall. You can see that image here with the placenta identified there, and this entire part of the uterus is basically placental growth, and the rest of the uterus is lying down there. This is quite an abnormal finding, of course, and no one wants to see it, but we were prepared, we thought. And the obstetrician, because of mother's wishes, wanting to preserve her uterus, tried to resect the placenta and left a 5-centimeter defect in the side of the uterus. Blood started pooling out of that 5-centimeter defect. The patient's face turned white. We started massive transfusion. Norepinephrine was started after phenylephrine infusion was completely ineffective in maintaining pressure, and we had about a 3.5-liter blood loss over a roughly 20-minute period. And this again is an acquired coagulopathy of acute blood loss. And as that blood loss is repleted with crystalloid or other substances that don't necessarily have clotting proteins and platelets, what we have is replacement of blood volume without replacement of those vital components, and this is a dilutional coagulopathy. Hemorrhage, of course, can come from many causes, and we have both uterine and non-uterine causes. Uterine causes are by far much more common. About 80% of postpartum hemorrhage is uterine in origin. The non-uterine, in my mind, are actually a little bit more concerning, and the reason for that is that we don't think about them in the moment. We don't see the laceration in the back of the abdomen. We don't see the intrapelvic or intra-abdominal or retroperitoneal bleeding until it's much more progressed. And so we often find non-uterine bleeding with much greater blood loss prior to discovery than uterine bleeding, which is more often associated with uterine atony. Management of postpartum hemorrhage, of course, has three important steps: identify and correct the cause of hemorrhage, and that is the surgeon's or the interventional radiologist's function; resuscitate the patient, which is our job; and then prevent further complications, including rebleeding and infection, which is everyone's job. The American Trauma Society has published comments on what they believe blood volume loss does to clinical measures such as pulse pressure, and blood pressure. And if I can get nothing else across in this lecture, it is that you should not use these numbers in the pregnant patient. Term or slightly preterm pregnant patient will not respond like most trauma patients. They tend to maintain their blood pressure, maintain their pulse rate until they finally fall off a cliff when they can no longer compensate. One of the better measures for obstetric hemorrhage actually turns out to be something that was discovered in this study by Deloitte. They looked at 456 women who had significant postpartum hemorrhage, and they found that of all the measures, the one that correlated best and the sole one identified on multivariate modeling was fibrinogen. Neither partial thromboplastin time nor prothrombin time correlated independently with blood loss. And what you can see here is up to 6 liters blood loss, all the way from 2 liters to 6 liters blood loss, the teams were able to maintain hemoglobin levels pretty well. You do not see a dramatic rise in either PT or PTT with that amount of blood loss. However, you can see a stark trend downward with the greater the amount of blood loss, the lower the fibrinogen levels in these patients. And this describes dilutional blood loss, right? So as you bleed more and as you're not replacing that fibrinogen, you eventually reach very low levels of fibrinogen. The amount of fibrinogen that you need to clot is actually much, much lower than what we usually concern ourselves with. This study by Charbet was actually a game changer, and this was a study performed in France looking at 129 people who were prospectively identified to have postpartum hemorrhage. And they divided these patients into a postpartum hemorrhage or a severe hemorrhage, defined by either a decrease of hemoglobin by 4 or more, transfusion of 4 units, or need for a hemostatic intervention, either radiologic or surgical. None of the patients died in their study. And the important part of this study was labs were drawn at time 0, meaning when they identified that this patient is having a hemorrhage, before they knew what group this patient was in, before they could get a delusional coagulopathy, they drew labs at the start of the disorder. And what they found was that women who had a non-severe, meaning less than 4 units transfused or less than 4 grams per liter drop in fibrinogen, had on average at time 0 significantly higher fibrinogen level. And as you can see here in the circle, many of them had completely normal fibrinogen levels at time 0. On the other hand, the cohort of patients who had a severe hemorrhage, right? Those patients who had a drop, who needed 4 more units, or who had a drop of 4, or needed a hysterectomy or uterine artery ablation, those patients had at time 0, before they even started resuscitation, a significantly lower fibrinogen level, and many of them had fibrinogen below 200 or 2 grams per liter. What is the interpretation of this? And I think this is probably the most important slide. It is that some patients have a dilutional coagulopathy where they start with a high fibrinogen, and as they bleed out because they have a surgical type bleed, their fibrinogen level is going to go down, as we saw in the study by Deloitte. Those patients can be treated with a normal massive transfusion protocol. They don't have to have aggressive repletion of proteins such as FFP or cryoprecipitate. On the other hand, in pregnancy, some pregnant women have a consumptive coagulopathy that is going on before we even diagnose that they have a massive hemorrhage. And those patients are identified by having an abnormally low fibrinogen at the start of hemorrhage. Women will form completely normal clot with a fibrinogen of 200 or even 100. You won't be able to tell that they have a low fibrinogen because those levels are normal for clot formation. However, a pregnant woman with a fibrinogen level below 2 is going to have an abnormal clot propensity because of a consumptive coagulopathy going on. And there you have to be much more aggressive with repletion of platelets, repletion of FFP, and other protein products. In conclusion, we did discuss the mechanisms of coagulation and how clot formation is a very complex process. It starts with tissue factor initiation, and usually in normal clot formation from a injured endothelial surface. In abnormal consumptive coagulopathy, that can be released by other cells such as white cells. We had talked about clot production or formation being really conducted on and around the surface of the platelet, which means that platelets are incredibly important, and understanding platelet function in this patient is essential. We identified changes in pregnancy and described the hypercoagulable state and how that forms and how it can actually affect some of the disorders that patients may have as pre-existing pre-pregnancy states. And then we talked about a number of examples of coagulopathy in pregnancy, including coagulation disorders, and the importance of understanding fibrinogen and how it predicts what type of bleeding this patient is having. Thank you very much for your attention.